morning, everyone. Thank you for joining us for this first in our series of webinars in partnership with Merck, Sharp, and Dumb called The Issues in Cancer Care, the Early Bird Series. It's certainly early, it's 8:30 a.m., and I'm grateful for your participation this morning. My name is Dwayne Schultes, and I'm the Managing Director of Vital Transformation. So lung cancer is responsible for roughly 1 in 5 cancer deaths in Europe. Last year, around 500,000 Europeans were diagnosed with lung cancer, and 400,000 of those people died of the disease. The survival rates are quite low, but thanks to improvements in diagnosis, surgery, radiotherapy, and new medications, they are getting better. The question is, should we screen more aggressively for lung cancer now or not? It's a very simple question. That's our thesis. And to discuss this today, we have two experts in the field. I'm very pleased to be joined by Anne-Marie Baird, the president of Lung Cancer Europe. Good morning, Anne-Marie. How are you?
Good morning. Good. How are you?
Thank you for joining us. And also by David Ritchie, the cancer prevention manager at the European Cancer Leagues. Good morning, David.
Hi, Dwayne. Thank you for the invitation.
It's our pleasure, sir. So to begin, Anne-Marie, what's your position at the Lung Cancer Europe? What's your position on screening?
Well, firstly, I just want to say thanks for the introduction and thanks for having me as part of this webinar today. And before I start, I'd just like to set the scene a little bit, as you have done there, that we are aware that lung cancer accounts for about 20% of all cancer-related deaths in Europe. And when we look at that in a little bit more detail, that means that around about 1,200 European citizens are dying from this disease every single day. So this is a huge, huge issue in the healthcare community. And as you've already alluded to, the poor overall survival, 5-year survival rate is linked to that. And of course, there's a number of factors that feed into a poor overall 5-year survival, such as the lack of awareness of the disease, the stigma associated with the disease, and the fact that the majority of people who present with the disease do so at a late stage, where then for most people, treatment is rarely curative. And of course, coming to the topic that we're on today, there is the lack of national lung cancer screening programs. For me, I believe the evidence is there to show that there is a substantial benefit of low-dose CT screening in significantly reducing mortality for those at high risk of lung cancer. And when we consider the costs associated with innovative therapies, all of the different healthcare burdens that's associated for caring with people with late-stage disease, I also believe that lung cancer screening, when performed appropriately in high-risk populations, will contribute to significant cost savings and benefits for healthcare systems. And there is some modeling data out there to reflect this. We know that the earlier someone is diagnosed with this disease, the better the outcome. And lung cancer screening can make a huge, huge impact for our community. I know it might not be perfect, but it does reduce mortality, and that is so important within our community. In the lung community, we all need to come in together, and we all need to buy in together for the widespread implementation of screening across Europe. We need to advocate for and promote investment in infrastructure, staffing, increasing the amount of funding that goes into research, such as translational research, implementation research, so that we can work on things like blood-based markers, breath condensates, AI programs, things like that, for example, improving our risk models so that we can make screening even more effective and get that false positive rate down as much as we can. I know with any screening program, there are always going to be concerns around harms versus benefits. And there is some data out there to show that there is distress associated with screening programs. However, this does seem to be in the short term. However, I would stress that we do need to ensure that any screening program educates participants properly on benefits and harms so that there can be informed consent, that there's improved education around screening and shared decision making, that there's help with the management of expectations and anxiety associated with screening, and that must be integral to any program. From recent work we have undertaken in Lucha, we have found that there is a significant lack of awareness around screening, and this really impacts how people feel about screening and their attitudes towards it. However, in work that we have done, people impacted by lung cancer do believe that the benefits outweigh the harms, and they would participate in a program if it was available, and they do believe that lung cancer screening can save lives and should be implemented. Early diagnosis will change the face of this disease. It will change the face of lung cancer. And to do that, we need to have the implementation of screening, because it is the best way to do that. Far too long, lung cancer has been at the bottom of healthcare priorities. It has been overlooked, but this must change, and it must start that change with lung cancer screening. Our citizens deserve better, and they deserve more. And we need to work to get lung cancer screening on any revision of the 2003 Council screening recommendation guidelines. And now really is the time to set up and implement large-scale programs. I believe we need to get going, and we need to get going as soon as we can.
Thank you, Anne-Marie. So David, Anne-Marie is talking about quite a large expansion of CT usage, putting in sort of regimes of screening. What's your opinion on that?
Thank you very much. And again, thanks for the invitation to be here today to talk about this important topic. As you've outlined about the burden of lung cancer, it's really a significant issue across the whole of Europe. And there are many areas in which we agree with Anne-Marie and her organization regarding the need to advocate for improved infrastructure, greater resources, implementation, research, improved risk models, etc. But when it comes to the question of screening via low-dose CT, we have to address this from our perspective when we talk about screening. And when we're talking about screening, we're really talking about the program, so a large-scale, complex, systematic program that involves inviting a large number of people who are asymptomatic, so to the best of their knowledge, free of the disease, and asking them to undergo a specific test. Sometimes this can be invasive. As Anne-Marie's mentioned, and as we all know on this issue, this always involves a trade-off between benefits and harms. It requires considerable investment in equipment, personnel, infrastructure, and IT data management systems, which imply a cost and can add strains to the health systems. And the overall goal of the screening programs, particularly what we're talking about in regards to cancer, is to achieve a reduction in mortality and not simply for an earlier diagnosis, so to speak. So these are some of the criteria that are involved with regards to approving or recommending a large-scale screening program. In regards to cancer specifically, so there are other forms of adult screening as well as pregnancy and newborn screening. But when we talk about cancer screening, the WHO and the 2003 recommendation from the European Union recommends organized population-based screening for 3 cancer sites at the moment: breast, cervical, and colorectal or bowel. These are also affirmed by the latest edition of the European Code Against Cancer, which is admittedly from 2014, based on evidence a few years earlier, so is in need of an update on latest scientific knowledge and insights. Our position as Cancer League's comprehensive non-tumor organ-based cancer societies, but comprehensive cancer control societies, our position is to focus on these programmatic screenings as recommended by, if you like, the high level guidance from the WHO, etc. So we're sort of constitutionally bound to follow this advice and guidance. And as things stand, this hasn't yet changed. Of course, the latest evidence and update of most significance comes from the excellent Nelson study published in the New England Journal in January, which give us some really important and powerful evidence regarding the capacity for low-dose CT to reduce lung cancer mortality. This trial shows that the efficacy is pretty clear of the tool of low-dose CT screening for lung cancer, but it doesn't really answer yet whether it's suitable for population-based screening. So you can't consider that the high-risk group, the people who are involved and were engaged within the Nelson study, as being the same as the high-risk group of people who would, in the real world setting, be invited to take part within a low-dose CT screening program. Essentially, this is translating the trial, the controlled scenario, best case scenario, into the real world scenario. And this brings up a number of complex questions regarding the organizational aspects of implementing such a screening program. And these are really now what needs to be addressed. So we've ticked the box regarding the tool of low-dose CT with this study, with the latest evidence. Now it has to go more into pragmatic, real-world evidence and implementation research. This is really focusing about how we can identify the population, engage with them, follow them up, and continue them into a screening protocol. And the difficulty here is that we're talking about a group which is based upon smoking history. So it's a high-risk target group. That information is not so easy to get as it is with the other recommended screening programs, which are defined according to age. So for example, currently stands with breast cancer, it ranges from 45 or 50 up to 69, 74. So you go from a register, population-based registry of sorts. Here we're looking to get some more complex information about smoking history, which will be a challenge to implement in practice. Additionally, this frequent smoking history, this frequent history of smoking quite heavily, is also clustered more into lower socioeconomic groups, into people in more material deprived settings, which itself presents challenges for the identification, the call and recall of these people over time, as they typically in the other screening programs don't attend as frequently as people from more affluent settings. So as mentioned, we have to consider this, consider the benefits and the harms. There are considerable harms in all screening, not just in this particular model. And then there's the cost effectiveness issue, which the studies have not yet reported on, to the best of my knowledge. This is not criticism, it's ongoing evidence to still generated. There's some indications it might be quite similar to mammography screening, but this is an area of urgent inquiry that needs to be done in the next steps before you can make a more robust recommendation. Needless to say, we need continuous quality assurance at every single stage of this process, and that's something that's also being worked on, but I don't think it's at an adequate enough stage yet to be able to be recommended more strongly. And then there has to be the effective data management systems taking into account this complex way of identifying and calling people to the screening. So considering all these factors, we have to add into the mix, as I mentioned about smoking history, the fact that this is really an issue located within the confines of tobacco control. Everybody who I've heard of talk about this issue agrees that the offer of low-dose CT screening for lung cancer has to be accompanied with cessation support, tobacco cessation offer itself. However, this is not uniformly available across Europe. There is not really a great investment. You could argue in some countries there's been disinvestment in basic tobacco control, and it's certainly not well funded, it's underfunded, and has suffered with the austerity across Europe in the past decade. So we have to also proceed with this issue in step with building and boosting capacity for tobacco control, offering cessation support, etc. And I don't think it's possible to really bring this screening offer out on a wide scale until you can be confident you have the resources and support for tobacco control there. And then finally, of course, there's the context of COVID-19 in the light of this pandemic and what that implications that has for our resources and for prioritization in the future. So in conclusion, we think we need to wait for more conclusive evidence taking into account resource implications, cost effectiveness, and harms.
Thank you, David. And again, I'd like to remind everyone who's listening today out on the audience, please feel free to submit your questions. We will be taking them from the audience, and we very much look forward to your input. We have had a couple of questions come in. I would like to touch on the Nelson study that you brought up, David, since you mentioned it. as you rightly point out, the study focuses specifically on outcomes, but there's really no cost containment there. And you also mentioned there have been recent studies that have been published looking at aggressive screening, or at least proactive screening. Certainly our firm Vital Transformation has done several of these studies that have been noted as well, where it shows that if you can capture early, you can defray costs, certainly further down the value chain. Now, isn't this also a systemic problem in that our health systems currently aren't defined to capture, measure, and quantify those savings? Essentially, you have a free rider problem. The person who pays for the screening is not the person who then saves the cost down the line. Isn't this also just a problem the way we're organized? How can we better align these processes? I'll start with you, David.
Yeah, I think that's an interesting point. But in regards to the LDC, the low dose CT screening, we have to look really at the cost effectiveness first of this issue. And this is not yet really understood because it's highly context dependent. We have a lot of information about the cost effectiveness from North America. Gives us some indication of the direction it might go. And then also within the UK, there's been some small studies published that show that it's actually quite favorable. But we need to understand a bit further, I think, before we can make any judgments along the lines of what you're saying. We have to understand a bit further what's the cost effectiveness of this potential program going to be in practice, considering also the need to have a sufficient and adequate optimal participation rate uptake in the future. This will also impact upon the cost effectiveness of any potential program. The indications from the states not so good, although I hear that they're improving. So this is really a big area of inquiry to establish what it's going to look like in practice, how cost effective it's going to be, what's the gains going to be for the health system. And then I think we can think about how then to use this to convince and shape the system to be more long-term thinking. Elsewhere, you can see this. I think the investment in the existing screening programs and vaccination programs show that they're capable of thinking long-term. There's been decisions, for example, in some countries to move to a gender-neutral HPV vaccination program from girls only, despite having very high rates of vaccinations for the girls, which was not really based on cost effectiveness, but was on grounds of equality and more political decisions. So I think there's potential to do it, but firstly, with this issue, it's about establishing much more clearly what's the cost effectiveness going to be in the various settings across Europe.
Thank you, David. And Anne-Marie, can you comment, please? What's your opinion about the cost-saving issue here that we're looking at long-term?
Yeah, well, I mean, I guess part of me wonders if we'd be sitting here having the same conversations if we were looking at the Nelson data in respect to a different cancer type. Because, you know, lung cancer does have image issues, and that does influence how people look at it and how people prioritize it. So I think that's one issue. I understand that, you know, the data around cost effectiveness still has to mature, and a lot of what it's coming out and is based on is data from the US. But of course, in Europe, the healthcare system is quite different. Even within European countries, the healthcare systems are quite different. But I think it's about nearly re-educating our healthcare systems and looking at this in a longer setting to show that over a certain period of time that there are going to be benefits made, and there is going to be that cost benefit made in the system. And I think as well as that, when it comes to screening, you know, we're going to have to look at phased approaches and targeted approaches. So really to seek out and start on those very high risk populations first. So the more hard to reach populations, I guess, is where you would need to start out first, where you're really gonna, I guess, as people say, get more bang for your buck, where you spend that. But I think, you know, continuing to talk about cost effectiveness all the time and putting all of our discussion and energy into that, you know, it is one thing, but in parallel to that, we need to get going. we still need to get ready for the implementation of this. You know, we need to prepare for maybe smaller pilot studies, because at the end of the day, this is such a healthcare burden, lung cancer, and it is affecting so many of our citizens across Europe. So, you know, just because something is hard or complex, you know, it doesn't mean to say we should park it until further notice. We need to get in there and we need to get going on it, and we need to try and work it out and really get that benefit translated to patients. And I think one of the other, and this will be my last point on this, I think, you know, people look at lung cancer screening and see it as a very complex thing to implement because of the infrastructure, the staffing, the CT, the reading, the scans, and all of those things. But there are a lot of issues in our healthcare systems already, and people are getting on with it. And I think lung cancer screening has probably highlighted a lot of the issues more, and that's made it a little bit uncomfortable for health systems to look at what they're already doing. So I think changes that would be implemented in a healthcare setting to help with lung cancer screening are going to have huge benefits for other areas of our healthcare system as well, not just lung cancer screening.
Thank you very much, Emery. We have had a bunch of questions come in here. I would like to start taking some of these audience questions. This is a question from Brian Ward, and he's mentioning, this is a reflection upon your comments, Emery. Would consideration of lung cancer screening be part of Europe's Beating Cancer Plan? Perhaps pilots can be rolled out as part of the new EU for Health funding program. What's your opinion on that, Emery? Do you think that would be something we should do?
I think it is something we should do. I think Europe's Beating Cancer Plan should integrate lung cancer screening pilots and things around lung cancer in more. I think sometimes when you look at cancer plans, there's a lot of focus on the more, I guess I'll use the term attractive cancers, and sometimes other cancers are overlooked. So I think when we look at the Europe's Beating Cancer Plan, we need to look across the board at all cancers and look at where there is huge unmet needs and things that need to be prioritized more. So my hope would be that with the two plans coming along, that lung cancer screening will be integral to those conversations and will help get screening off the ground in Europe.
Thank you, Emery. There's just a comment here from Mary Bussell regarding the discussions of cost effectiveness. What is the value we put on a human life? Okay, thank you, Mary. Mary, just to be clear, in New Zealand, it's only $15,000 Australian or New Zealand. In the US, it's $200,000. Fundamentally, from a quality standpoint, it's depends on where you are, but I understand your point. Unfortunately, that is part of the issue. Try and get new technology in New Zealand. Good luck. It's going to be it's going to be very difficult. Another question from Mary. This is for you, David. I'm interested in understanding from David, how many years of screening and trials do you feel would be necessary to show benefit? What are you looking for as a practitioner? What would you like to see?
Well, I go back to when I first had meetings and conferences and project work and talking about this topic maybe 10 years ago. And Dr. Antti Atala was giving, from the Finnish Cancer Registry, was giving a presentation showing the cycle, let's say the ideal theoretical model where you go from demonstrating effectiveness in a trial to doing the real world pragmatic study, to doing piloting, to doing rolling out, and then you have a nationwide program, either regional or national. You're looking like 10 years or so maybe, but it's hard to say. I mean, I think the good thing about, we should look at this maybe not retrospectively in terms of trying to mimic what was done, for example, with mammography, but look towards the future. And the future of screening is definitely going towards more targeted approaches. So if you think about in mammography, we're involved in a trial called My Personal Breast Screening, which is integrating alongside the traditional factors of age, polygenic risk score, and some other risk factors like parity, etc. So this shows how you'll then start to segment the targeting of the people to offer them different, in the case of mammography screening, a different schedule. But that gives you, I think, the direction of travel for the future, where the research is going, is to have more complicated structures and more complicated ways to identify the people that are based upon more, if you like, individual factors. So taking into account that, it could arrive sooner, maybe that there's demonstrated effectiveness in small scale demonstration studies where people have got new models to identify people. But crucially, it's getting the person into the screening, informing them in a proper way, linking it with cessation support, and not losing them in the follow-up afterwards. And as well, keeping it all the way through the continuous quality monitoring support that we have to have at every single stage throughout, which is also a big investment. It takes time, but with the new developments, it could be sooner, but it's certainly not right this moment. There's still a lot to do, and that's the implementation, demonstration, research focus that's needed.
Thank you, David. We have a question here from Imran Farid. Should we move to a value-based model where industry is benefiting financially from the increased spend on drugs are paid based on the improvement, so the marginal improvement of an outcome? Obviously, this requires a technological infrastructure to do so. Anne-Marie Baird, again, quickly, we're running out of time, but how do you feel about outcomes-based procurement and payment?
Well, I think there is some research already going on in this area, and a lot of the medical societies are looking on this and have certain algorithms and things like that available. But again, across Europe, given different health services and systems, and given the difference in how they look at, just because something's approved by the EMA doesn't mean to say it's going to be reimbursed in your country and you're going to have access to this drug at the same time as other people across Europe. I think we need to do more around this area and see how we can sort of balance that out a bit more. And it will be interesting to see as the projects and the data matures from those medical societies on the approaches they're taking in this area.
David, any comment on outcomes-based payment, reimbursement, procurement?
Given the time, I would direct you to our website, cancer.eu, and to our Access to Medicines Task Force, who deal with this specifically. It's more on the treatment and access to medicines perspective. And in regards to prevention, again, we're talking about balancing the benefits and harms, establishing the cost effectiveness, and seeing, we've established that this lung cancer mortality reduction through CT. So now we want to see what happens in the real world and get moving with demonstration projects to address these open questions.
Thank you, David. Okay, final question for both of you. Again, we're almost out of time. Boy, that half hour has flown. Anne-Marie Baird, if you have one recommendation right now, one tangible recommendation you could make, what would you like to see done first?
I would like to see us work towards getting lung cancer screening on the EU Council recommendations, because having that will really provide that impetus for EU countries to start working then on getting lung cancer up and off the ground and benefiting the people that are impacted by this disease.
Thank you. And David, from your perspective, what one recommendation would you like to see?
Definitely those countries that can do it should look now at demonstration projects, small scale studies, but they have to locate this within the wider context of tobacco control. I know that not all lung cancers are linked to tobacco use, but when we're talking about this particular screening method, it is based around the tobacco issue. So we have to ensure that going forward with this issue, we're also thinking about investments and support that can accompany it within tobacco control, offering cessation for current smokers, etc.
Thank you, David. Again, just to remind everyone, this is part of a series. We're doing the Early Bird Debate Series. It's a bit of an experiment. We didn't know how it was going to work. Obviously, had a huge outpouring today. Thank you very much for your participation. The next session will be on July 8th at 8:30 a.m., where we'll be looking at head and neck cancer, the cancer you can see. We very much look forward to your participation. You can register at vitaltransformation.com. And again, David, I'd like to thank you, and Anne-Marie, I'd like to thank both of you for your participation. Very exciting session. Thank you very much. And for the audience, thank you. So with that, I call this webinar closed. Thank you, everybody.